Hello, ladies and gentlemen. Welcome to today's video. In this video, we will review the modified Duke criteria for diagnosing infective endocarditis. If you are new to my channel, please subscribe and press the bell icon. It would be hard for us to make such content without your kind support. So let's begin our video. The modified Duke criteria help clinicians diagnose infective endocarditis based on clinical findings and laboratory results. Let's break it down into its components. First up, we have the major criteria. These include 1. Positive blood cultures for infective endocarditis causing bacteria. These include typical microorganisms consistent with infective endocarditis from 2 separate blood cultures. Examples include Viridian's streptococci, Streptococcus bovis, Hatzek group, and Staphylococcus aureus, or community-acquired enterococci in the absence of primary focus, or microorganisms consistent with infective endocarditis from persistently positive blood cultures are defined as follows. At least 2 positive cultures of blood samples which are taken 12 hours apart, or all 3, or the majority of more than 4 separate cultures of blood, with the first and last one taken at least 1 hour apart, or single positive blood culture of Coxiella burnetii or antiphase AI immunoglobulin G antibody titer of 1/800. Multiple samples should be taken from different venipuncture sites. 2. Evidence of endocardial involvement. This can either be a positive echocardiogram for infective endocarditis. This is defined as oscillating intracardiac mass on valves or supportive structures in the path of regurgitant jets or on implanted materials in the absence of an alternative explanation, or abscess, or new partial dehiscence of a prosthetic material, or new valvular regurgitation. Remember that worsening or changing of pre-existing murmur is not sufficient. Also note that a transesophageal echocardiogram should be performed in patients with prosthetic valves rated at least possible infective endocarditis by clinical criteria, or complicated infective endocarditis, EG paravalvular abscess. In all other patients, transthoracic echocardiogram should be performed first. If a patient meets any of these major criteria, it strongly suggests infective endocarditis. 2. Minor criteria. Next, we have the minor criteria. These are factors that can support the diagnosis but are less specific. They include predisposing heart conditions or IV drug abuse, fever, temperature more than 38 degrees C, vascular phenomena, major arterial emboli, septic pulmonary emboli, mycotic aneurysm, conjunctival hemorrhage, intracranial hemorrhage, or Janway's lesion, immunological phenomena, glomerulonephritis, Osler nodes, Roth's spots, and rheumatoid factor, and microbiological evidence, defined as positive blood culture, but does not meet major criteria as already outlined, or serological evidence of active infection with organisms consistent with infective endocarditis. Based on these criteria, the patient can either have definite or possible infective endocarditis. The patient is said to have definite infective endocarditis if there are 2 major or 1 major and 3 minor criteria. On the other hand, if only 1 major and 1 minor or 5 minor criteria are present, the patient is said to have possible infective endocarditis. The diagnosis of infective endocarditis is considered rejected when 1. Firm alternative diagnosis, explaining evidence of infective endocarditis. 2. Resolution of infective endocarditis syndrome within 4 days of antibiotic therapy, or 3. No pathologic evidence of infective endocarditis at surgery or autopsy with antibiotic therapy for less than 4 days, or 4. Does not meet criteria for possible infective endocarditis, as previously described. Thank you for watching this video. Please support our work by subscribing to the channel.